vein whose job it is to absorb all of the fluid from GI to get it delivered first. It's called the hepatic portal vein. And that hepatic portal vein, you'll get an increase in its tension. They call that hepatic portal hypertension. And when a person with liver failure or liver disease gets hepatic portal hypertension, they're going to be at risk for the serious hemorrhoids and the kaput medusa. Yes?
So with the liver disease, the arteries are leaking water? Or?
Everything gets damaged, Mama. Because what happens is, see, the liver is something, the liver has a dual blood supply. The liver cells require their own arteries and their own veins because they have their metabolic needs and then their metabolic waste that they have to push out. But then separately, they have to mix that capillary bed that they require for themselves. They have to mix that with what they're receiving from GI, which is all venous blood that's nutrient rich and oxygen poor. So the liver cells have to learn how to work under low oxygen content blood because all that blood is pulled. The arterial blood coming into the liver to give it its oxygen is being pulled with that nutrient. And then the blood that's coming in to feed the liver is nutrient rich and oxygen rich. But it's getting pulled in with nutrient rich oxygen poor blood from GI. And then it's bathing the cells. And then that blood is being pulled back and brought into the inferior vena cava through the left and right hepatic veins. So the liver cells, for the most part, it depends on where they're at closest to the entering arterioles that come into the liver. So those that are closer to the arterioles, they call them zone 1. Those that are further away, they call them zone 3. And zone 3 are more susceptible, especially when you start talking about a reduced amount of oxygen for whatever reason, or because of the inflammatory response, the extracellular matrix of the liver, the glue that keeps the liver cells stuck together, it starts to change and it increases in thickness and consistency. And that reduces the blood flow to the area. Well, that can lead to necrosis of the liver. The cells will die because they're not getting good enough blood supply. But they're kind of used to living under this low oxygen, levels that they're constantly being delivered. So this is what happens. It takes time. So this offending agent has to be there for a while. And this can be, I have a friend, and I'm sure some of you know this already because those of you who took me for 28.5, I talked about it when we talked about bone. A friend of mine, good-looking guy, was playing football for Rutgers, right? And he grew up in Jersey. I was born in Jersey. And he grew up going to the Jersey Shore all the time, just like I did. And I didn't have a boat, but he had a boat. So his family had boats. They would go out and they would get oysters. And he would eat all oysters off the Jersey Shore. I don't recommend that. He did it, and he almost lost his life. He lost half of his liver, and years later, when he finally got out of the hospital, his joints were attacked. So, you guys, you hear about this, the red tide? Mm-hmm. This is no joke. This stuff gets into shellfish. You eat the shellfish raw, you get red tide. You get red tide, you could die. And if you don't die, you will have issues. And sure enough, he could never walk the same again. His joints were deformed. He was always in pain. And he still had issues with his liver. He looked old and frail, and he was walking with a limp. So this is for real, guys. Now I answered this question for you. Why is albumin so important? Because albumin reabsorbs 90% of what we call the interstitial fluid, the fluid that bathes all cells. Well, so somebody's got to ask me the question. Where's the other 10% going? Mm-hmm. Is it going to stay there? Can 10% of that fluid stay? What would happen if every time fluid flowed in, 10% of it stayed in the tissue? We keep accumulating, guys. You can't have any accumulation of fluid. Other than the little bit that's required, everything else needs to move the hell on. Can't have that in here. Especially when we're talking about stuff like brain. You follow? So that 10%, This 90% is going back into the venous side of the capillary. That 10% is getting absorbed by lymphatic drainage. And that's lymphatic vessels. Blind-ended capillary vessels. They look just like this. They'll absorb that 10%. Look like finger-like. And they're simple squamous epithelium with a basement membrane. That's exactly what they are. That takes us into lymphatics. So I know I skipped over heart. But why? Because the student asked, what did you say about albumin last time? Because I looked at the video and I remember not. Because sometimes I'll sit and I'll watch the whole video from end to end to see, I'm kind of scatterbrained. I'll mention something, I'll write on the board, and I'll start talking about something else and I'll forget about it. So please, when that happens, please remind me, right? There's a little something that I forgot. So I could clarify it for you then and there. But that albumin is key. So that capillary, you have the venous end, and that's where you're going to get the reabsorption of 90%, and the other 10% will go to lymphatics through this lymphatic drain. Okay? So guys, you see, if I have elephantiasis, if I have filarial worm infection in the lymphatic drainage, then what will happen? If I block this finger-like projection, and I prevent that 10%, what would happen? Elephantiasis, that's what will happen.
Yeah, that's where you get swollen.
Elephantiasis. Where do we see this? Underdeveloped worlds where kids are walking around, underdeveloped countries where kids are walking around without shoes. You understand? Even in the Caribbean, you can get it. You little worms. They go right up into the cuts of the skin, and then they'll go and they'll find the lymphatics, and they'll block the nearest, closest lymph node they can find. And because the lymph node is distal to this, then it blocks the lymph node drainage, and fluid builds up. And so that 10% is supposed to be pulled into here. It never gets in there because now it's being pushed out. Now it's accumulating. Guys, you see that? If this fluid accumulates, can it lead to the preventing of fluid moving out at the arterial end? Yeah, it can. What do you think the elephant man died of? He didn't live very long. If you look up, how old did the elephant man, look him up. How old did the elephant man live for? What, 20, 25? Maybe 30, yes.
In the case of a patient with liver disease, the interstitial fluid is going to accumulate at the abdomen side too.
It could, so you're going to get ascites as well. That's correct. That's right. And then if you push it, it'll go one side to the other. Observations. It's all about looking, seeing, and then touching and evaluating. They're called palpation. So you use your hands to palpate. Then you use your ears to auscultate.
For 27
so
years.
you can hear there's a certain tympany to ascites in the abdominal wall. And guys, this is why you want me or somebody like me in the clinical scenario when you go in there. Somebody who's knowledgeable of all this stuff and then has patients say, look, come on, I want you to hear, look, listen to this patient who doesn't have ascites. Now, come over here. I have a patient who has ascites. I want you to hear the tympany in the abdomen. And so when you use your fingers, it's like it'd be like listening to the quality of sound of this with water in it versus it being empty. You hear? It should be empty. You'll hear that difference in quality sound, that tympanic difference, guys. You see? And this is why we have these things. If you want to be healthcare workers, why you need them. All right? It'd be really hard to be a doctor if you couldn't hear.
He was 27 years when he died.
Yeah, look at the eagle. Guys, it's not rocket science. It's not. It's not. How long do you think the cardiovascular system is going to work at this? When you've got 10% of fluid building up regularly in every one of the organs, and it's only a matter of time because these little worms, they jump from one lymph node to another, Sure enough, it starts up the toe, and the foot, and the lower limb, then the other limb, and then all contoured, and then the head and the face. And how long do you think it will last? So fluid builds up everywhere, and then it's it, multi-organ failure. Yeah, guys?
Yes.
Because this stuff has to move out and move back in. It can't. If I have excess build up here, then what's supposed to move out doesn't move out. That means then I'm creating this back pressure that makes it harder for the heart to push what it needs to every time it beats, guys. You get me? Any questions so far? So this has to do with blood, because albumin is in the plasma. But it's in really, they talk about it more so in the capillary system or in the blood vessels. So you go to the last chapter, chapter 19, they'll talk about all the forces. Because why, guys, watch. What is the predominant extracellular protein in connective tissue? Does anybody know from last semester? 2085, my 2085 class. What's the predominant molecule that cells make outside of the cell as an extracellular protein? Type 1 is found in bone, and type 2 is found in cartilage, and type 3 is found in blood vessel walls, and type 4 is found in the basement membrane of capillaries. Collagen. Collagen, guys. Collagen. So collagen sits out here. And collagen, normally, in an organ, the collagen concentration should always be standard. This is its level. It should never change. You understand? In cirrhosis of the liver, the collagen levels increase. Oh! See that? When that concentration of collagen levels increase, then the fluid that gets drawn out will it'll have an increased effect. That protein, as that protein level increases, it'll draw more fluid out. So this is another force. Remember I told you there were 4 forces? Then fluid that accumulates in here, and of course, because remember, we're generating CO2 and water, right? From mitochondria and metabolism. This is the normal process. So when we do that, the water that gets generated actually can push back. So there's another force, and that force is what we call a hydrostatic pressure force. I'll write it over here. Let me erase this. And that little force there, they call that the hydrostatic pressure. So wait a minute, Professor P. We got 2 hydrostatic pressures here, don't we? Everyone agree? We have a hydrostatic pressure of the capillary, yeah? Mm-hmm. Capillary. And then we have the hydrostatic pressure of the ISF, yes? Then we have the effect that collagen has on drawing water out. That's called the osmotic effect or the oncotic effect. Okay? The movement of water is called osmosis. That effect is called the oncotic effect because the protein has the effect of drawing water out. This is why you need a certain amount of collagen in the connective tissue. So, guys, these are the 4 forces. Now, look at them. Which 2 are in the same direction? The force that's due to collagen, they call that the oncotic pressure of the interstitial fluid because it's due to collagen. So then what would we call this one? The oncotic pressure of the capillary. Oh, it looks like the door locked behind them. Can somebody open that door for me? Can you open that door for me? Somebody's trying to get in. Or for her. So, guys, just like collagen as a protein has this oncotic effect on the amount of water, right? Was it somebody? No, check it. Oh, no, somebody now. All right. So, just like a collagen has that effect on water, albumin has that same effect. So, we call this the oncotic pressure, all right, of the plasma. And that's equal to the concentration in albumin. Guys, you see where I'm going with this? Yes. 2 forces are going in the same direction and 2 are going in the opposite direction, yes?
Yes, sir.
So in basic math, we would do what? Add the 2 forces that are going in each direction, yes? Yes. So these 2 forces and then these 2 forces get added, yes? And then to determine how much fluid moves out, what am I going to do? Subtract the values of the 2 added values. Did you guys hear me? And that's how we can figure out how much blood gets fed to each and every one of the organs. And again, considering that albumin must stay at a certain concentration always, and that's liver's job, and that collagen's concentration at each of the tissues is determined by the fibroblast cells that are responsible for the formation of collagen. Does everyone agree?
Yes.
Or when you're talking about bone, the bone cells, remember the osteoblasts and osteocytes that make collagen, type 1 collagen for bone, right? Versus type 2 collagen in cartilage, that's made by chondroblasts and chondrocytes. You agree? Oh man, I'm taking it back, man. You guys thought you'd have to know that stuff. There was a madness. There was a method to my madness. There's a reason why I covered that information when we did it last semester. Collagen is the most important extracellular protein that a cell could ever make. Of course, albumin is also important too. Because why? Albumin is extracellular, made by liver cells, but it's made specifically to stay in the tube always. Always stay in the tube. Guys, you hear me? If you find albumin, if you have a patient and it shows up that there's protein in the urine, you'll assume that it's albumin. Do you see why that's an issue? Yeah, because if I'm losing albumin from my kidneys, then that means the capillary that was designed to keep albumin in has holes in it that are too large to prevent albumin from leaving. And that means you've got issues with your kidney. You're probably a diabetic. Because diabetics have an increased risk for renal failure.
So we find the in fluid, blood, and
everywhere.
urine.
That's right. No, you don't find it in urine. If you find it in urine, then something's wrong. It should never be in urine. It should never leave the bloodstream.
Oh.
It's always meant to stay in the bloodstream because its job is to control our ability to reabsorb at the venous end of the capillary, and its also job is to carry hormones to deliver them to the tissues. If you find it in the urine, then that patient has that patient has renal failure, some form of renal failure, right? Because if you're finding specifically albumin in the urine, then that means that there's holes punched out in the process, and we'll get to that when we get there, right? But the holes are too big, and that's telling you your nephrons are dying. They're not able to sustain the solid, simple squamous epithelium. Now, that's important too, because if you talk about the lining of the blood vessel, some blood vessels are really tight. So like in the brain, you remember the blood-brain barrier and the blood-testes barrier? They're very tight junctioned. Nothing gets through. Everything gets selected to come through, but it has to go through the other cells. Those are called astrocytes that create the blood-brain barrier. Everybody follow me?
Mm-hmm.
But in other places like the liver, there's huge window spaces between a simple squamous and another simple squamous. They call that fenestrated capillaries with a discontinuous membrane. Did everybody hear me? So fenestrations we got windows. But discontinuous capillary means we got physical sections where they're separated. And in the liver, because the liver's job, guys, again, what's the liver cell's job?
Filtration.
Well, it is to filter what's coming from GI and then figure out what to do with it and determine metabolically where to send it. Yes. It's also involved with inactivation of medicines. 50% of all medicines that one would take, they'll metabolize them and put it right back into the fecal material. So that means if for $100 of medicine that you just gave the patient, for every pill you give them that's $100, 50% of it is being shit down the toilet. So they're literally shitting $50 down the toilet, right? Literally. And you do that with any medicine, 50% of it. So that's normal. Separately, the liver is responsible for making coagulation factors and angiotensinogen, yes? Separately, it's also responsible for making albumin. Damn, man, liver got a whole bunch of shit to do. And this is a huge protein albumin has to make and then physically put into the vascular system. Do you see why their capillary is discontinuous? Because I got a shit ton of stuff I got to dump into the bloodstream. You do not want me to give me a really well sealed blood vessel. I don't want that. That does me no good. Do you see why? If the connective tissue increases between the cells and the blood vessel that I'm supposed to be putting my proteins into, if that distance increases and I put more connective tissue, make it thicker. Do you see that I can't get what I'm making into the bloodstream, guys? You see that? That's cirrhosis of the liver. So you'll have the cells will try their best to make everything that they need to and then try to deal with the offending agent. Because the liver, remember, and the liver what? As at one point is the site of hematopoiesis, isn't it? That's a good question on the test. Because remember we said, they leave yolk sac, HSCs leave yolk sac.
Yes,
huh?
they do.
They leave yolk sac, all right? So let's go on. So, all right, so the hematopoietic stem cell, guys, that gives rise to the red blood cell, to the megakaryocyte, all right, and to the white blood cells. Now, the red blood cells, I'll never ask you guys about all the different cells and their maturity. I don't care. I care more so that you know that red blood cells don't have, that the functional red blood cells that are existing in the periphery of blood that are working every day to provide oxygen and glucose to you, or oxygen, they have no nucleus, no mitochondria, no ER, no Golgi. Everybody understand me?
Mm-hmm.
They're nothing more than a bag full of hemoglobin. And we're going to talk about that now. Red blood cells, functional, erythrocytes. Circulating erythrocytes, mature erythrocytes. I don't care about the erythroblast cells and none of that other stuff. But the mature erythrocytes are nothing more than bags of hemoglobin. And hemoglobin is nothing more than 2 alpha polypeptide chains with 2 beta. I'm just going to put, that's a beta, this is alpha, and polypeptide chains. So 2 beta, 2 alpha polypeptide chains. They look like this on the outside. And they have to all come together to work together as functional hemoglobin. So functional hemoglobin. But that's not all they need. So to be functional hemoglobin, you don't just need the 2 alpha polypeptides and the 2 beta polypeptides. So, wow. All right, we'll go green. 2 alpha, 2 beta polypeptide chains, guys, all right? Then, we're talking about hemoglobin. That's not all I need. This would be my alpha, beta polypeptide chain. Well, within the middle of that polypeptide chain, you have this flat carbon ring. And it's complex. Flat carbon ring. And I draw it like that not because I'm trying to be silly. I'm drawing it because it kind of sort of looks something like that, and it's a little complicated, but they're flat carbon chains. And those flat carbon chains, well, they're called. So you need 4 proto. Yeah. All right. So that's called porphyrin. Protoporphyrin. So you need 4 of these. So I need 4 of those flat carbon chains. And then finally, I'll need an Fe+2 in the center of each of those flat carbon chains. And I'm going to need all 4 of these to come together with all this to make functional hemoglobin. Okay? So you can see why, hey, if I'm deficient iron, what disease am I going to have? Anemia. Iron deficiency anemia. If I have a lack of folic acid, I'll get a folic acid deficiency that could lead to anemia. Vitamin B12 is involved with the synthesis of these hemoglobin molecules, so you need vitamin B12 on board to make proper hemoglobin and the protoporphyrin ring. So if you have a deficiency in vitamin B12, you have a vitamin B12 deficiency anemia.
I have that. Vitamin B12 deficiency.
Now, there are a set of kids who are born to mothers who are Rh negative. Did everybody hear me? They're Rh negative, meaning they're red blood cells, guys. So remember, I'm talking about, this is the molecules that exist in the red blood cell. The mature red blood cell looks like this. And that red blood cell, give me 3 more minutes right here. That red blood cell has one of 2 proteins that it can have. A or B, or A and B, or nothing at all. You hear me? So if I'm A, then I have A antigen. So type A has A antigen. A antigen. Type B has B antigen. Different from A. So I'll draw a circle. And type AB would be what, guys? Be both. A and B antigens on the surface. So that's this guy. And if I'm type O?
None.
None. Now watch. No A and B. Okay. Now watch, guys. My red blood cells aren't just blood cells. They're floating around in blood plasma. Does everyone agree?
Yes.
And one of the things I told you that was floating in blood plasma was a soluble set of proteins called antibodies, IgG and IgM, made by B cells. Everybody hear me? Now, when I put this guy in your blood, if you are type A, would you want antibodies to type A in your blood plasma? No, because if you had type A antibodies to type A antigen, then your blood would coagulate. You hear me?
Yes.
So in their blood plasma of a type A cell person, they have antibodies, they have B antibodies. They're positive to B antibodies, but not A. So their antibodies are for recognition of circles that they don't have, not the triangles that their red blood cells do have. Got me?
Yes.
Then when I go and look at who's B, then in the plasma of the B, type B person, am I going to find A or B antibody?
A.
I'm going to find A antibody. So there I'm positive for A antibody. If I'm AB blood, then I look in the plasma.
No.
Would I have antibodies for A or B?
No.
No, because if I had either one, then I would react. Do you see that? People who have AB are at risk for certain infections, and we don't know why. Could it be because of this inability to generate antibodies to our own self-antigens? Yes, it could be. Could be something bigger.
And then type
So there are no A and B, or B antibodies, right? Then guys, if I'm O, meaning I have no antigens on my red blood cell, then what does my plasma look like in terms of
A and
antibodies?
B.
It has A and B. So in the plasma of someone who's O, I'm positive for A and B antibodies. So do you see now why? Type O blood. I'm type O. I can give type O to other people, but I can only take from type O. Now, this idea of RH is a different story. In this one case, you get an anemia of a newborn because the mother's Rh negative, the father's Rh positive, and nobody ever did the first test on the first pregnancy. So the baby was born and the mother got exposed to the baby's blood products. And the baby was positive like daddy, but mommy's negative. So when mommy gets exposed to the blood products of Rh positive, she makes antibodies to that. And if the next baby's Rh positive, she'll destroy the red blood cells of that baby. That's called autoimmune disease of the newborn. All right, guys, have a good weekend. We'll see you on Tuesday where we'll talk some more. We'll go about the heart. We'll hit the heart and